Okay, well, I'd like to thank the moderators and sages for the opportunity to present. This is my disclosure, so I'll leave that up a minute. So when to obtain imaging? So I practice out in Utah, out in the West, and I am not an emeritus professor. So a lot of my patients come into my office with minimal workup, and we want to have access to me because I'm trying to build that practice. This is a relevant topic because my administrative staff and secretary and nursing team have spoken a lot about these different things. I'm going to talk to you today a fair bit about esophagram and how that can be useful, and then briefly CT scan and very briefly gastric emptying studies as they pertain to imaging. So when to get an esophagram? So my opinion about these, this has been very, very helpful in my practice. If a patient comes to me, they don't always come with even an endoscopy. But I usually try to get this imaging study on everyone who's coming into the clinic because it can really kind of help guide the patient's future workup. And it also sort of gives me maybe a clue before I walk in the door as to what sort of symptoms they may or may not be having, what story they may tell me. There's a standard barium esophagram, and so these are static images. So if a patient comes down from Montana to Utah, they're not going to come with a video. Usually they'll come with some pictures that look like this, and these can be useful for a few things. So assessing the size and the nature of a hiatal hernia. So there's a nice lady who's having a dysphagia problem. Looking at esophageal length, so here's a man with a very bad long segment stricture, and so kind of looking at that, anticipating he's going to have a very short esophagus. He actually wound up getting an esophagectomy and did not have surgery with me. Diverticula, so here's a lady with regurgitation, but it's not from a hiatal hernia, it's from the zinkers here that she has. And then to help guide future workup, so here is a very nice gentleman who had a very useful manometry as an aperistaltic esophagus, and so that's why he's having regurgitation. His esophagram was read out as normal here in the static images. Some technical pearls about this. So in researching this talk, I spoke for a while with a radiology friend who's very into fluoro. And some things I gleaned from it. So if you're doing fluoroscopy yourself, as we were doing in my fellowship with some of the patients, know that assessment for hiatal hernia is best done when the patient is prone. If you're starting a program and you're hiring a fluorotech or talking to radiologists, you're bringing in a new reflux practice, you want to lie people down. Sometimes you'll see small hiatal hernias that may be missed on an upright study. Some other pearls, so the tubular esophagus goes down to just above the diaphragm, and then there's this area here called the vestibule. So, when I look at images myself in the clinic, I will look at something like this and sometimes say, oh, well, the radiologist missed a hiatal hernia. But it's important to know that there's this bulbous distension of the esophagus that is kind of the distal 2 to 4 centimeters, and this really manometrically corresponds to the lower esophageal sphincter. And so in doing the study, if the patient holds the breath or the Valsalva, you may see this here. And my question for my fluoro colleague was, well, how do you differentiate this between a vestibule and a small hiatal hernia? And the answer is to look for the rugal folds there. So in this image, you can see the rugal folds down below the diaphragm, whereas above this is quite smoothly contoured. This shouldn't be mistaken for a hiatal hernia. And certainly doing endoscopy yourself and looking manometrically can kind of help elucidate that too. So video esophagram, very, very useful, and sometimes will show things that I would have missed had I just had static images. This person has a static image, and obviously maybe they have kind of a motility problem going on there. But more subtly, video can demonstrate subtle strictures and obstruction and webs. It can show you a lot about bolus clearance, and also kind of help you glean some peristaltic information in addition to your static images. Certainly not a replacement for manometry, but can really kind of anticipate and augment some things. It's important to note here that reflux episodes are not always seen on a video study. It's a short study, in a finite amount of time. And I think really important point here that is made in several of the papers that I took a look at, you shouldn't use a video esophagram to help you decide definitively whether or not someone is having pathologic reflux. So if you gave me a cup of barium and you had me lay flat, I might have some funny things going on, with how I was swallowing that in my lower sphincter as well. And there are a couple of papers down here that kind of drive home this point. So one, people who truly had pathologic gastroesophageal reflux, fluoroscopically, reflux events were only observed in 35% of those patients, whereas in this other study, people were having spontaneous GERD. And this was demonstrated in 40% of asymptomatic volunteers. So don't let that be kind of your pathognomonic diagnosis maker for whether or not the person is having pathologic reflux. So some technical things here when doing a video esophagram. My friend in radiology reminded me that the pharynx and the upper esophageal sphincter are best assessed upright, along with penetrance, so airway protection, thinking about extraesophageal symptoms. Usually the patient will do 5 individual swallows in both the upright and supine positions. It's good to try and assess at least a couple of swallows if you can with solid material like a capsule. Sometimes you'll see that capsule hanging up like it is in this patient here. Normal esophageal peristalsis, so there's a primary contraction that propels the bolus through the esophagus, and very normally you should have a secondary contraction kind of cleaning up the leftovers. Normal subjects, by definition in this study, can clear a solid barium bolus, so that little tablet with 4 swallows in the upright position. Anything else is abnormal. Video esophagography can also show you this problem here. So this is a lady who, it turns out, has an aperistaltic esophagus. We discovered that she has scleroderma, and you can see kind of these bubbles just sort of hanging out in her esophagus and falling down by gravity. So diminished peristalsis, non-propagating contractions, incomplete bolus clearance are nicely illustrated here, as well as sometimes some more spastic motility disorders such as diffuse esophageal spasm and jackhammer. You can see the contractions. So moving on to CT. So do we ever get CT in evaluating reflux? And the answer is sometimes I do. So there are a few places where I think this can kind of add a little bit to your preoperative risk assessment and discussion with your patients. I like to get CT scans in people who have had a prior anti-reflux surgery, and I don't do this all the time, but I do it if there's an atypical symptom. And in a lot of my patients that I meet in clinic, they had an openness in the 80s. They had something where we try to get the operative notes, none are available. And so here are a couple of people who I met who have some mesh at the hiatus. And so for me, that's going to add a little bit of an extra paragraph there to my risk discussion. It's when I book the case, it's going to add a little bit more to my operating time. So that's nice to know before I go to the operating room. Pain or abdominal symptoms of unclear etiology, so lots of chest pain and reflux, but people that are having abdominal symptoms that don't make sense. I picked up a couple of gallstones, kind of like what Dr. Jackson was speaking about. Prior history of bariatric surgery, I think it's a must. If you're thinking that the patient has reflux, it is really nice to see anatomically what is going on with their prior bariatric operations. And then occasionally somebody that has sort of a funny picture, so dysphagia and EJJ outflow obstruction that isn't really manometrically a classic diagnosis and is unexplained by the esophagram. And I'll show some case studies just to demonstrate this. So here again is my mystery Nissen in the 80s patient with the circumferential mesh there around their esophagus, and we found a nice erosion on endoscopy. Here's another gentleman that came in. He was really interesting. 54-year-old man referred by GI with just an endoscopy and this history. So he's got some chest pressure and dysphagia. He has regurgitation that's refractory to maximal medical therapy. But he also had a fair bit of crampy abdominal pain, kind of upper abdominal pain and dyspepsia. And he has an endoscopy from GI, and they say, well, there's a large hiatal hernia, and maybe there was some gastric volvulus, the antrum's above the GE junction. And this is what it looks like. So again, not having done this myself, it's hard to assess where's the diaphragmatic imprint, what's going on here. So the abdominal pain, though, was confusing. So we got this CT scan here. And he has a couple of things here. He has a very sort of, in-your-face renal cyst here that turned out to be a benign entity. But you'll notice the majority of the guy's small intestines and his pancreas and his colon and pretty much everything else is sitting up there above the liver. So he had a pretty wide crural diastasis to go along with this. We had a very different kind of, operative discussion about risk-benefit, longer operation. I booked it for some more time. Here's another person, 72 years old. She had a history of a gastric bypass 15 years ago, and she was referred for heartburn and a very small hiatal hernia for a crural repair. And because of the bariatric history, we got this CT scan to evaluate her regurgitation and her bloating. And she's got this very distended roux limb here that you see in the left upper quadrant of the image. And what this was she actually had an adhesive band at her jejunostomy, and the roux limb was kind of chronically partially obstructed and dilating up. And so when she eats, her pylorus is offline, so that's all coming up into her throat. So we took her to the operating room and did a lysis of adhesion and addressed the band, and she actually felt completely better from a symptomatic standpoint. Another person here, this is a gentleman, 45 years old, came in with reflux and dysphagia, pretty profound solids dysphagia. So we get manometry, and he actually has normal esophageal peristalsis, but he does have a slightly elevated IRP, so EGJ outflow obstruction. We got an esophagram, and it really looked relatively normal, and so we get this CT kind of looking for a pseudoachalasia type of a picture. And so he's got this mass here at his GE junction. This was actually a very dense lipoma, so we went in and fixed this man's hiatal hernia, pulled the lipoma down, and his dysphagia completely resolved. So a little bit unusual there, but the CT was very helpful. One last kind of thing that, you may or may not consider this an image. I will confess that I usually don't. Usually I'm kind of looking at the report, but occasionally, I'll kind of be looking at the pictures and it'll actually help me with clinical decision making. And that's the gastric emptying study. So it's something to consider in, for my practice, people that come in with nausea, true vomiting, so not regurgitation when you bend over, but emesis, using the diaphragm, bloating, and then a history of prior anti-reflux surgery, a little bit more suspicious about gastroparesis, and so obtain this study. This can be done in the classic way with a 4-hour scintigraphy or with a new wireless gastric motility capsule. And the protocol is called the TOGAS protocol. So they eat radio-labeled eggs in my institution, and they get pictures at 1, 2, and 4 hours. And you see the abnormal values there. So here's a case where looking at the pictures actually helped. So this is a patient that comes into clinic, and he's had 2 prior Nissen fundoplications, and he has some issues with solids dysphagia and regurgitation. He's been on maximal medical therapy for a year, and it's helped his heartburn, but not these other symptoms. He's got a little bit of bloating, but no early satiety. And incidentally, he's had a prior partial colectomy in the past for colorectal cancer, and he's followed, and he's NED, but he has problems with loose stools. So we get a gastric emptying study, and here are the results. And so at 4 hours, 24% of the material is still in his stomach, so they read that out as kind of moderately delayed. And he and I are having a discussion about redoing his fundoplication, fixing his recurrent hiatal hernia. But should we do a pyloroplasty? And he already kind of has diarrhea, and as we know, dumping can be a side effect of that operation. And getting ready for clinic, I was looking again at his esophagram, and you see his recurrence there. He has a Nissen that has slipped onto the body of his stomach with a small recurrent paraesophageal hernia. And then if you look at the images from his gastric emptying study, all of that radiotracer is just hanging out in the proximal stomach. So truly, if he had kind of a vagal nerve injury and he had antropyloric discoordination, would that really be the case? And so it kind of made me question that a little bit. And I spoke to some colleagues, and I spoke to the patient. And at the end of the day, we decided to just do his repair, do a nice partial fundoplication in case I was wrong about the pyloroplasty, and not do the pyloroplasty. And he feels fantastic, and his gastric emptying is normal, and his diarrhea is made no worse by me. So looking at the pictures was very helpful in that case. So I think if I was going to give you just a quick summary of kind of when to obtain these studies and why they're useful, esophagram is really, my favorite. It gives you a great preview of the size and nature of the hiatal or paraesophageal hernia you're going to be dealing with. Nice assessment of esophageal length, whether or not there are strictures present, diverticuli, obstructions. Video will show you some nice information about peristalsis and bolus clearance, but is no substitute for manometry. And is really, really, I think a good thing to take away. It's not a good test for pathologic gastroesophageal reflux. You shouldn't hang your hat on it. CT is nice if people have had prior anti-reflux surgery, particularly if you don't have an operative note. If they're having abdominal symptoms that don't really make sense with their reflux picture, prior history of bariatric surgery, I think always, you might be surprised at what you find. Dysphagia and EGJ outflow obstruction that are unexplained by esophagram and manometry. And then gastric emptying study, I think consider obtaining this in people who have significant gas bloat, nausea that is chronic, not just when they're having reflux, but they feel kind of car sick all the time, early satiety, true vomiting, important to differentiate that from regurgitation for a variety of reasons. And then any history of prior anti-reflux surgery. And occasionally taking a peek at those images and where that tracer wants to hang out can maybe be helpful. So thank you very much.